Paige. Jen and I work together over at the Incontinence Center just next door. I'm a urogynecologist. I started with Methodist in '99 as a general OBGYN, and I got board certified in urogynecology as the time went on, and that's my focus now. I quit delivering babies. And so this talk is about how people end up getting to surgery for their bladder, and then Jen's going to talk a little bit about education surrounding surgery, and then Ashley's going to go over enhanced recovery, some of the new techniques we're using to improve surgical outcomes with what we do. So, like I said, I'm going to go over the indications for surgery, the different types of surgery, postoperative care, and follow-up. So, two of the main reasons people end up in the OR or on the floor post-surgery is for pelvic organ prolapse. So, the bladder, the uterus, or the rectum are falling out. It can be all three components of the vagina or just one component. And so they're going to the OR to have that fixed. That may or may not include a hysterectomy, and that may or may not include an anti-incontinence procedure. So you have pelvic organ prolapse and you have urinary incontinence. And this is going to outline both of those indications in more detail for you. And so you have normal anatomy. You have the urethra, the bladder. This is a picture of the uterus. Some women are post-hysterectomy and don't have that. And then the rectum. And then you have all of the pelvic floor muscles. We like to describe that kind of as a bowl of small muscles that hold everything up there. The reason a lot of women have prolapse is because of childbirth injury. That tends to be the first and foremost insult to the pelvic floor. So you have a baby, it can be traumatic, large baby, operative with forceps delivery, that sort of thing. Those nerves and muscles become injured and traumatized. A lot of younger women are able to compensate for that and get through to menopause. Then when you have the changes of menopause that come, the tissue quality changes, you lack estrogen, and a lot of women become more symptomatic with their prolapse. And so a lot of women that end up having this surgery are age 50 and older. You will see some 30 and 40-year-olds that have issues, and that can be actually because they have more of a genetic component, their tissue quality is weaker, or they just had such a traumatic childbirth that they need surgery at a younger age. So a lot of these women will come to see us or their primary care physician or their gynecologist because they actually feel tissue at the opening. They'll have dryness or irritation to the tissue. Some women will come in, they're still menstruating, and they can't get their tampons to stay in. They get expelled. Or their bladder is falling out so low that they can't empty their bladder, have recurrent infections, or voiding dysfunction. So again, this is kind of what I went over already. Pregnancy and childbirth is one of the main reasons. The menopausal factor, chronic conditions such as coughing or constipation. We have patients that come in that are chronically constipated. They're bearing down to have a bowel movement. Those patients we see have large rectoceles. The rectoceles, when the posterior wall of the vagina is bulging into the vagina, you can imagine stool will pocket in there. That initial injury is usually from having a baby. A baby comes down, goes against that posterior wall. It separates the fascia that normally holds it in place. And then you constantly have constipation, and the bowel movements make that bulge even more. Genetics, like I talked about, some people just have weaker tissue. Heavy lifting. We see a lot of factory workers that come in from small towns around the area, and they lift 50, 70 pounds. Those patients inevitably have some degree of prolapse and incontinence. Obesity and smoking. So treatment options, a lot of times one of the first things we talk about is their bowel habits. Are you taking Miralax, Colace, that sort of thing? Increase your fiber, increase your water intake. Try to avoid the heavy lifting if you can. I've had some patients that can't quit their job in a factory. They have to keep working. I don't want to do surgery on them and send them back to the factory, so we'll put a pessary in until they're done working, and then they'll have surgery after that. Lose weight, do pelvic floor exercises. We have an amazing group of physical therapists right over here, right next to our office, and probably 75% of our patients with incontinence and pelvic floor relaxation will do some pelvic floor physical therapy. And we have patients get complete resolution of their symptoms, not the prolapse necessarily, but incontinence to at least 50% of resolution of their symptoms. Pessaries are devices that can be inserted in the vagina, both to hold up prolapse and to put pressure against the urethra to help prevent leakage with cough and sneeze. They also have new little poise inserts. Maybe you've seen ads for them, but they're like little tampons that can go behind the urethra to help with incontinence. If you're going to go for a run or something like that, you can insert one of those, and that can help with leakage. And then surgery. So here's a little bit more detail of the types of prolapse that there are. A cystocele, so that means the bladder's coming down. Anterior prolapse is when this tissue right here, so here's normal bladder, and this is a cystocele. So most women, the majority of prolapse we see is the bladder. So if I'm doing a pelvic exam, I separate the labia, I have her bear down, you'll see the vaginal rugae and that bulge coming out at you. And so you can imagine urine can get trapped in here. You might not empty all the way. That can lead to both infections and continence issues. Not to mention the discomfort of just feeling the bulge down there. Here's the rectocele. And so this is the descending colon. This is the anus where the stool should come out. It just bulges in the vagina. And some patients have to splint, so they'll actually take their hand and push the bulge up in order to get the stool to come out. And then uterine prolapse. It's not very common that it's just the uterus coming out. Usually, you'll see the cystocele first, and then the uterus will come behind it. Occasionally, there are a few patients that have only uterine prolapse. And you can see in that bottom right hand, that is everything. That would be called complete uterovaginal prolapse, where the whole vagina essentially turns inside out with the cervix and uterus as well. So going through our algorithm of treatment, we start with behavior modification, pelvic floor exercises, maybe a pessary. If patients have tried those things and they don't make them comfortable enough, then we start talking about surgical repair. And here, the incontinence piece of it as well, that often goes hand in hand with the prolapse. So when talking about urinary incontinence, there's stress urinary incontinence, and there's urge urinary incontinence, also called overactive bladder. Stress incontinence, I think, is the most, common thing people think of. And when we talk about surgical repair, a sling is meant to fix stress urinary incontinence. Overactive bladder or urge incontinence is most often treated by behavior modification, like cutting out caffeine or medications. And so stress incontinence, straightforward, is a weak urethra. The urethra is normally a muscle that stays closed all the time. A normal urination is your bladder fills, it gets to your bladder capacity. You sense that, you say, okay, I need to go, you find the restroom, you go into the bathroom, you get your pants down, you sit down, the urethra relaxes, and your bladder muscle, the detrusor muscle, contracts and the urine comes out. Stress incontinence is when that urethra muscle is not strong enough to hold the urine in, and you exert some extra pressure on it, and urine just squirts out. Some women have such a weak urethra muscle, we call it a lead pipe urethra. It's just open all the time. There's hardly any pressure holding it closed, and those are usually the very elderly patients that just the action of standing up can cause urine to leak out. And so, again, these are all the things that can play into that. The overactive bladder can be a little harder to treat. That can be caused by dementia, just aging alone. The neurogenic bladder, people with multiple sclerosis, other types of neurologic issues can have it. Recurrent infections or irritation to the bladder. Sometimes we don't know why people have it. A lot of our patients with urge incontinence have had previous back surgery or issues with their back, and diabetes is also a big factor in it. So urge incontinence is more, gotta go right now. You've seen the commercials where, okay, I have to go to the bathroom and I can't get in there fast enough now, or you guys are all classic. You've waited far too long to go to the bathroom, and then it starts coming before you get there. And so back to the office exam, we have a long questionnaire that we have our patients fill out that tells us in more detail, when are you leaking? Is it the stress? Is it the urge? What are your main symptoms? And so we have them, we review all of that history with them. We do a thorough pelvic exam. One of the things that we look at is the bladder neck hypermobile. So again, separating the labia. If you have them cough or bear down and you see the urethra swing down at you, that's called a hypermobile urethra. And so what's happening when that occurs is that tube, the urethra, is funneling open, and that's the anatomical change of stress incontinence. And so we have a good idea of that just on exam if that urethra muscle is weak. And then if we decide to proceed towards a more invasive type of treatment like surgery or InterStim or something like that, we do a urodynamic study in the office. And that takes about 45 minutes to an hour. A small catheter with a pressure sensor goes into the urethra and the bladder. It gives us information about that pressure inside the urethra. How weak is it? It gives us an idea of the capacity of the bladder, if the bladder is having overactive contractions, if they empty all the way. And so we have all of this information prior to surgery, which helps after surgery in case patients don't pass their voiding trial. We know ahead of time, did they come into surgery not emptying their bladder all the way? Do they have bladder spasms? Is that why they're so uncomfortable afterwards? That sort of thing. So again, kind of a summary of treatments of both types of incontinence. The behavior modification is always our first step. We want you to be optimizing, when you're drinking your fluids, how often you're going to the bathroom, pelvic floor exercises, pessaries. In between getting a sling and a pessary, there is a less invasive procedure called urethral bulking. That can be done in the office. Occasionally we do it in the OR, but we take a cystoscope and go in through the urethra and bulk up the inside of the urethra. We used to do it with collagen, kind of like filler for your lips. We're filling up the inside of the urethra to provide more resistance there to the urine flow. We don't think that that's quite as effective as a sling, but a lot of patients who don't want to go to the OR or too elderly to go to the OR, we'll try the bulking agents for them. And some people get great relief from it. Sometimes they have to come in for a second treatment of it. But we have that in our armamentarium of treatment options for them. And then the gold standard for stress urinary incontinence is the midurethral sling. The overactive bladder. Behavior modification is a huge component of that. A lot of people will come in and say, I don't know why I have to go to the bathroom every hour, and then they're drinking tons of fluids, lots of caffeine, which can be an irritant. And sometimes when we just clean up some of their behaviors, they'll notice a big difference. The pelvic floor physical therapy, one thing that is just a little piece of information that can help many patients is you feel that urge, you're trying to get to the bathroom in time, you do something called quick flick Kegel exercises. You just squeeze those vaginal muscles really kind of quickly. Just take your time, don't rush, and sometimes that bladder contraction will pass and you can get to the bathroom in time. There are 7 or 8 medications that we can use to try to treat overactive bladder: Detrol, Ditropan, Myrbetriq. Once a daily medication that oftentimes will treat many of those patients. We can inject Botox into the bladder. It's a paralytic, so the bladder muscle that spasms, we inject directly into that muscle via a cystoscope. As soon as the Botox kicks in, that bladder muscle relaxes and people don't have that overactivity anymore. There's sacral nerve stimulation, InterStim, or tibial nerve stimulation. Those are both stimulation of the InterStim is the sacral nerves feeding down to the pudendal nerve, which innervates the bladder, and that just blocks that bladder from spasming. The tibial nerve, they come in, it can be done in the office. We place a little needle into the tibial nerve, and it goes up from below to do the same thing. When patients get tibial nerve stimulation, they usually come in once a month to get treatment for that. And maintain that, and they can often get good results without having to go to the OR. So types of surgery. Does anybody have any questions thus far?
Is that Botox done in the office?
Mm-hmm. Yeah. Yep, most of the time we do it in the office. Occasionally, if we're doing something else in the OR, we'll give it in the OR as well, but it's really well tolerated. So the anterior repair fixes the cystocele. The posterior repair fixes the rectocele. The apex, the top of the vagina, where the uterus is, or the cuff, if they have already had a hysterectomy, we can do a sacral colpopexy, which is done abdominally. I do that robotically, or it can be done open, or the uterus sacral or sacrospinous ligament suspensions, which are done through the vagina. Sometimes when we're doing a repair, we have to do a hysterectomy just because the uterus is falling down or is technically just in our way from what we're doing. If you're doing a vaginal repair, like the uterus sacral or sacrospinous suspension, you do a vaginal hysterectomy. If you're doing a robotic sacral colpopexy, you take the uterus out robotically. A lot of times if we need to do the robot because the uterus is enlarged, we'll combine that with the vaginal repair. So everybody gets their own picture of what kind of surgery they have depending on the surgeon and their preferences, and then what defects they have. We determine that going into it for what they're going to need. The colpocliesis is when you're essentially closing down the vagina. So you can leave a uterus in and just kind of attach the tissue to itself so it can't fall out anymore. That is not one of my preferred procedures. I just don't think, I think if you try to repair the anatomy to its original state, you'll get better bowel and bladder function. So I don't do colpocliesises. This is the anterior repair. So this is going in through the vagina. We open up the vaginal skin, dissect the bladder from the vaginal mucosa, and then we plicate it. So we try to get the good fascia that has torn underneath there and bring it together. And then we close the vaginal skin over the top of it. The same thing for a posterior repair. This is just on the back side. And so we get this fascia here and try to pull it together. Sometimes patients don't have any good tissue left. Just if you think of like an abdominal hernia repair that the general surgeons do, sometimes they just stitch it, suture repair. Sometimes they have to put a mesh in. So sometimes we will use some vaginal material to repair that, to augment the patient's own tissue. There's some debate about using mesh in the vagina. We use some xenografts, which are animal or human fascia, or we can use a synthetic mesh. But you worry about it causing problems like eroding through the vagina and causing pain and bleeding. So we always use caution with those things. And this is the abdominal sacrocolpopexy. This is my favorite repair. I do it robotically, which I think really helps with recovery time for the patients as opposed to having an open incision. This is a diagram of the vagina right here. So we dissect the bladder off of the vagina in the front and dissect the rectum off of the vagina in the back. We attach a synthetic mesh to the vagina, and then we pull it up. This is the sacrum, and so we anchor it to the ligament that's on the front side of the sacrum. That, in my opinion, just gives you a more natural anatomical plane. The vagina goes straight up the way it should be. When it does that, it pulls the bladder up and the rectum up. Some patients then will still need a little distal vaginal repair. So a patient may have an abdominal sacrocolpopexy, a posterior repair, which is usually the distal 3 or 4 centimeters, and then a mid-urethral sling oftentimes because they have incontinence and a weak urethra as well. So that's kind of my blue plate special now, is to do that to get a good repair for patients. Here's a picture of the robot. I don't know how many of you have been in the OR or seen it, but the patient is over here on the side. We usually have a bedside assistant. Bonnie Wilkerson is my PA, and she will be at the bedside, and I'll be over at the console working. On my sites, my assistant port is over here, so they end up usually having 5 incisions on their belly. This one is usually the biggest. If you're up on the floor taking care of these patients, patients might have a little more tenderness here and a little more tenderness here, or the assistant port. The reason this one gets bigger is because if they've had a uterus, we have to remove the uterus from the abdomen. The technique I currently use to do that is I'll if it's too big, I'll put it within a bag and I'll morcellate it and take it out of the abdomen that way. That incision has to be about 15 millimeters in size, and so we end up closing the fascia with a stitch, and that makes them a little more tender under there. The other reason, if you ever take care of robotic patients, the assistant ports will always be more tender because the robotic ports are on a fulcrum and they don't cause as much trauma to the tissue. The assistant port is moved by the assistant and just automatically causes some more trauma and some more discomfort, and that's why those incisions will be more tender. Here's a little
A hysterectomy, which is the removal of your uterus, can be done through one small incision in your belly button with Da Vinci surgery single-site technology. Da Vinci is a robotic-assisted surgical system that allows your surgeon to operate with 3D high-definition vision and smaller, precise hand movements, all done through just one belly button incision. To perform this minimally invasive procedure, your surgeon will first carefully detach the uterus on its right side using tiny instruments and a tiny camera with a light at the end. After the uterus has been detached on the right side, it's gently moved away from the bladder. And next, your surgeon will delicately detach and free the uterus on its left side. The uterus is then carefully separated from the cervix, or your surgeon may separate your uterus from the vagina. This step in the procedure will be based on your surgeon's choice. And finally, the uterus is gently removed from your body. And once it's removed, your surgeon will securely stitch the top of the vagina closed. The end result for the patient having the hysterectomy is virtually scar-free surgery.
So that was a single incision Da Vinci case, and so not a lot of people here do single incision, and that was just for a hysterectomy. To do the abdominal sacrocolpopexy, they have to have more incisions, but in general, that's how the robot works. Do you guys have questions? I didn't talk much just about general gynecology. Hysterectomies are often common as well. And what Jen's going to talk about as far as pre-op and post-op, everything pertains the same to hysterectomy and pelvic floor stuff as well.
Hey everybody, I'm Jen. So I am Dr. Charleston's nurse practitioner. I was a labor and delivery nurse for 17 years at the Med Center, went back to school, have been with Dr. Charleston for 5 years total, a year in my training and 4 years in the clinic. So we work together as a team from the day first we see the patients all the way through their recovery. So I'm going to go through some things, post-op expectations, things that we teach them in the clinic, things that would be normal for you to see in the hospital, and things that we would be concerned about. So the big thing with our patients is if they've had an anti-incontinence procedure, they still may have some bladder symptoms in the hospital. And those can be driven from a lot of underlying issues, like Dr. Charleston had talked about. If they have overactivity, that is not something that is fixed by placing a bladder sling. Some patients will have inflammation from their surgery, depending on the extent of that. So they'll have irritation around the bladder, or they'll be having some bladder spasms. So just reassuring the patient that some of those things can be normal. Maybe they're not emptying well. So we do that bladder study in pre-op during the clinic to make sure that they have a normal bladder squeeze, that they empty well, and there isn't an underlying issue there. Sometimes with the swelling, placement of the bladder sling, patients just cannot get their bladder to empty in the hospital, and that can cause them to have more bladder spasms, bladder pain, or what we call overflow incontinence, where the bladder just gets so full and it forces urine out. So I know that some of you that work in the hospital have asked, what can you do to help those patients? So reassure them. A lot of people, when we talk pre-op, one of their first fears are, am I going to have a catheter for the rest of my life if something goes wrong here? And so the answer to that is no. It may be temporary, but no. So just really encourage them to relax, let the pelvic floor relax. We don't want them to push or make any extra effort to try to get their bladder to empty. Who works in the hospital with the post-op patients? Anybody that's here right now? Yeah. Okay. Does that help you kind of understand a little bit if they struggle? So the next thing is bleeding. That's always the question, is how much is normal bleeding? Well, it can definitely vary amongst patients, provider, and the type of procedure they have. Some patients may have as minimal bleeding where you're just having spotting with wiping. Some people can have more like a light period. So as long as their vitals are stable, they're not having pain, the rest of their physical exam is okay, your bleeding amount can be as much as a light flow. Now, if they're soaking a pad an hour, they're uncomfortable, they're having a rigid abdomen, you're seeing vital signs change, that's too much bleeding. Vag packing. So a vag pack is placed at the time of their surgery, and part of the reason of that is to provide them some extra support vaginally when they're being extubated, if they're having some nausea, vomiting. It just gives them some more support. So that typically comes out the next morning, and then you can evaluate their bleeding better. Now, if they're soaking through a vag pack, you would definitely need to call for that, because that tells us that there's an increased bleeding somewhere within that repair. Pain expectations. That's always hard. Everybody has a little bit of different pain tolerance, their past history of surgeries, how much work they've had done internally. Some things, from a post-op standpoint, when we see the patients in the clinic, whether we see them for an early post-op visit or their routine 4-week, we do tend to see younger patients tend to have more pain. Patients with posterior repairs, or the backside of the vagina that has been tucked, they tend to be more uncomfortable. So if you've had vaginal bursts and had any episiotomies, that's tender for a while. We sit on that area as a bowel movement passes by. It can be more uncomfortable. So in the clinic, when I talk to them about post-op repairs and expectations, I encourage them to do more side sitting, not to be sitting up on that for long periods of time. We talk about a good bowel regimen, and we'll talk about that in a little bit, just to help prevent constipation or having a big, fuller stool pass through there. Obviously, if we have patients with existing chronic pain, they're going to have more pain post-op. That can fire up the nerve pathways and can trigger some overall generalized pain. From our standpoint in the clinic, we have close communication with their pain management doctor, and so we add on any additional medications that they suggest for them post-operatively. Patients with a history of adhesions. So if they've had multiple abdominal surgeries, if they have a history of endometriosis that may cause scarring, their surgery lasted a little bit longer, then you can expect those patients to be a little more uncomfortable in that immediate post-op. So avoiding trial. So the majority of our patients do have avoiding trial complete before they go home. Not all providers will order that, but any patient that has had pelvic floor surgery or repair, definitely any patient that's had an anti-incontinence procedure, it would be appropriate to do avoiding trial. So the purpose of doing avoiding trial is to make sure that the patients are emptying well, and that when they go home, we're not going to have any issues with retention or pain related to that. So I am not sure, in the hospital, do you guys fill their bladder up, or do you take their catheters out and let them drink and then empty?
We do both, just
You do both on the provider. Okay. So a voiding trial can be done two ways. So you can either do an active voiding trial where you will backfill the bladder. We do about 300 mils in the clinic. Take the catheter out, let the patient go to the bathroom and empty, and then we do a scan over the bladder to make sure they're doing a good job. You can do it passively where catheter comes out, you're letting them drink, they accumulate urine, go in and void, and make sure they're emptying well. Our parameters are we want patients to have under 150 mils of urine in their bladder, and we consider that a successful voiding trial. Every provider can have a different parameter based on their comfort. We covered that. Questions about a voiding trial?
So a normal person with no problems would not have any urine?
So they can have anywhere from 0 to 150, and for our patients we would consider normal. So there can be some gray area in there because all of us have a different bladder capacity. You know, a normal bladder capacity, we hold 300 to 600 mils. Well, some of us, if you've been a floor nurse and you go all day, you might hold 1,000 mils. So would we be okay with that patient having 200 in their bladder and they feel empty? Probably. But I think in the hospital they get a pretty set standard. But when we see them in the clinic, so if the patients don't pass a voiding trial in the hospital, catheter goes back in, they'll come see us in the clinic the next day, and we'll repeat that voiding trial. And so then we look at what's the bladder capacity and stuff and making the decision moving forward.
And you use like the urodynamic studies that you've done.
Right. Right. Yep. So reasons people don't pass, we talked about this a little bit, inflammation around the urethra and just the tissues that support the bladder neck. It can swell that up and they can have a difficult time passing. If we give them even 24 hours of rest with the catheter in, most of the time those patients will pass their voiding trial when we see them the next day in the clinic. So if they've had a bladder sling placed, sometimes there's too much tension under the urethra, and the patients just cannot get their bladder to empty. So if we see them the next day in the clinic and they don't pass their voiding trial, we give them a couple options. We either put their catheter back in and have them come back in the next day or two, or we can teach them how to self-cath 3 or 4 times a day or as they need, and buy them a few more days and see if we can pass that voiding trial. If they still cannot pass the voiding trial, then they'll go back to the operating room with Dr. Charleston, and she'll release the tension on that sling a little bit. And then they'll be able to redo the voiding trial and such. It's rare that that happens, but that is a risk when we place a sling. The other thing that we talk a lot about in the urodynamic study and that I go over with them pre-op is what kind of voider are they? So a lot of times we empty our bladder. We don't really think about how it happens. We just do it. And so as women, we are classically in a hurry. Like going to the bathroom is an inconvenience. So we want to be in and out of there quick. And by doing that, a lot of times we're straining to hurry up and get the bladder to empty. Women that have had bladder behaviors, leakage and such, they will Valsalva or push a lot because they really want the bladder to be empty, thinking that's going to help them with leakage. So when we do a pelvic floor repair, if we place a bladder sling and they now have support, if you envision this as your urethra and this being a sling, if we have somebody that's constantly bearing down, they can actually put a little kink in that urethra and stop the flow of urine. So we really want to re-potty train them, for better words, and teach them how to just let the pelvic floor relax, let the bladder squeeze without them straining. And so when you're dealing with them in the hospital, that's one thing you can just reiterate to them is just make sure they're just letting their pelvic floor relax and the bladder do the work. So, and I think we kind of talked about what if they don't pass their voiding trial. So the other thing that I do is I do their post-op teaching. And so for the first 4 weeks, any of our patients that have had pelvic floor repair, no heavy lifting. I tell them really nothing heavier than a gallon of milk. I don't want them doing repetitive pushing like vacuuming, bending, dragging, anything like that. Some of our patients really don't have a lot of pain. They don't have a lot of pain in the days moving forward. So they feel pretty good, and they think they should be able to do multiple things. I caution them if they're slowly starting to increase their activity, they're having more pelvic floor fullness or cramping, they're probably doing too much. Avoiding constipation. So we can have a lot of post-op complications from not moving bowels. We can have bowel ileus, we can increase pain, it causes a lot of tension on their fresh incisions. So our patients go home with a printed bowel regimen, Colace twice a day, Miralax once a day. If they've not had a bowel movement by day 3, we want a phone call, and we have them start little bits of milk mag every hour. If they've done that for 6 hours and haven't had a good bowel movement, we have them use a suppository. So they go home with education that I assume you guys probably reiterate for them in the hospital. Nothing in the vagina for 4 to 6 weeks. Intercourse, bathtubs, anything like that. And when should they call us? So fevers, increase in bleeding, if they're feeling flu-ish, incisional pain, redness, they think they could have a bladder infection, they think they could have a vaginal infection or a urinary tract infection, we encourage them to call. I go over all that with them in the hospital too, or in the clinic, so hopefully they retain some of that between me and then what you guys teach them going home. We typically see our patients all at 4 weeks. Some providers, like Dr. Brecken, who's in our partner, she sees her patients at 6 weeks. We absolutely will see them earlier if their surgery was a little bit more complicated or if they're having any issues. Yep, we talked about that. So at 4 weeks, Dr. Charleston will do their exam, depending on how they're feeling, the type of procedure they had, if there's still suture present. They can either restart slowly adding back to their normal activity at 4 weeks, or we have them stay on pelvic rest for 2 more weeks and then slowly increasing. I do teach our patients that even though things look well healed on the outside, that our body still works on healing tissue for up to 12 weeks. Pelvic floor physical therapy, like Dr. Charleston said, we utilize them a lot. Sometimes we use them preoperatively, sometimes we use them postoperatively. So if a patient has a prolapse, a lot of times they can have muscle laxity. So even though we can improve their tissue quality and put everything back into its normal position, you can still have very weak muscle tone. And so it's important for them to be able to exercise and bulk those muscles up. They also learn a lot of lifestyle changes. So avoiding heavy lifting, how to protect your pelvic floor if you are a woman that does moderate to heavy exercise or you work in a career where you're doing a lot of heavy lifting, pushing, pulling. Any questions for me at all?
Are there any basic exercises or things that you know that they recommend in physical therapy that you would suggest?
Yeah, so everybody knows about Kegels, and that's something we talk about preoperatively. We talk about at annual exams. Both Dr. Charleston and I make sure a patient knows how to do a Kegel. It's just the assumption that we do, but surprisingly, some people are very uncoordinated in that, and they're actually pushing instead of pulling up and doing more damage. So on a daily basis, whether or not we have a surgical patient or not, they're counseled about Kegels. And so that is something that's addressed in pelvic floor physical therapy, but they teach them so much more about the pelvic floor and how to exercise. As Dr. Charleston said, our pelvic floor is innervated with nerves, muscles and nerves that come from all directions. And so they need to be able to exercise the muscles, not just from the sides, but front and back and up and down. So
in general, we don't like them doing too many of them immediately post-op because it can cause more pain and discomfort for them. So usually we wait 4 to 6 weeks before they restart pelvic floor.
anything else?
I'm just going to share a little bit about enhanced recovery, and I have experts in the room I've identified, so so if you guys, I'll try and get your input too, because I would love to have the perspective from those that are actually practicing this now. Who in your current practice is using enhanced recovery? Or are you familiar with the enhanced recovery? No? Yes, a couple. I know two. Okay. You'll see ERP or ERAS. Those are kind of some acronyms that you'll see. ERP is just Enhanced Recovery Program, and ERAS is Enhanced Recovery After Surgery. And so this is just kind of the new update, kind of the new wave that ACOG is recommending. We have an Enhanced Recovery Society. If you Google that, they have tons of information on it. But this is the new suggestive way that we want to take care of our patients during surgery, after surgery, to enhance their recovery. So it's very obvious. I will say that in just asking some of our leadership and our clinical specialists here at the hospital, why are we not doing this yet? Or, what are the barriers to starting this process for different surgeries? And it really is that multidisciplinary approach. So it requires the buy-in from so many modes and so many healthcare providers and different avenues. And so it really can take a long time to get that going. I know we have some gynec patients that use it at Maine, and then you guys, it sounds like, have a lot more different patient groups that use it too, which is awesome. But it requires, the buy-in from our nurses preoperatively, our physicians preoperatively, from anesthesia, from the nursing staff intraoperatively, and then afterwards as well. So it can take a lot of time to get these processes in place, but hopefully this will provide you guys with just an overview of what it looks like, what the standard is, what they're suggesting for our patients, and then how it really does help improve. Some of these things, I will say, with the discretion, you probably can do. They're very basic. And then some would require orders and things like that, that hopefully, if you're interested in it, I can give you research so you can start standing up for your patients and talking with your service leaders and seeing if that's something that you guys can kind of get moving and researching on your own as well. So it does cost very little. And when we look at the cost savings, I'm a research nerd, so I like to know the background of that, but it can save an average of $153 to $697 a day per patient. And so for very little cost to implement, that's a big savings if we look at how long they're staying, how many patients we have coming in and out, especially those one-day stay surgeries that we have. That's a lot of savings. So, and then obviously it would decrease our length of stay and complications for our patients as well. Any ideas of how we would save money from that? By decreased length of stay and specific reasons why that would happen? Yeah, yep. How about after discharge? Like, how would it impact them after discharge, do you think? They return to work faster because they have a shorter recovery. Any other thoughts? Decreased caregiving burden, so they don't require a lot of assistance after surgery, which is fabulous. And then, two, we see a lot of readmission to like the emergency rooms and to urgent cares and different things like that from complications too. So, okay, so this is an overview of kind of what we'll talk about, and I'll go into a little bit of detail and give you guys some statistics and things. But when we look at the 4 components, the first one is pre-admission. So this is all the education that Jen was talking about. This is the probably most impactful. It's free. It doesn't require extra money to implement. But when we educate our patients on what to expect during surgery, what to expect after surgery, when to call the provider, all those different things that she mentioned, and then we reinforce that preoperatively, after surgery, before they go home, when they follow up again in the clinic, it really does show, research shows that it reduces their anxiety. Even prior to that surgery, to begin with. They're prepared. They know what to expect. It improves their fatigue after surgery. So, again, they know what to expect. They know how to care for themselves, how to manage that pain ahead of time, and then we can just keep reinforcing that. They have decreased pain, decreased nausea. They have early discharge, so we see a decreased length of stay, and then their satisfaction is increased as well. Another component to the preoperative aspect of it is tobacco cessation and then decreased alcohol use as well. Smoking cessation, it's recommended that they stop at least 4 weeks prior to surgery, and that does show us in research that it decreases their post-op complications significantly, so that's a fun fact for you that you can share. And then often we can see in patients when they follow them up to 12 months post-op, if they have decreased their tobacco use at least 4 weeks prior to surgery, they are more likely to have decreased use at 12 months. So it actually helps with the sensation long-term as well. You guys probably know nicotine provides an analgesic response in our patients. So if they are still smoking, prior to surgery, if we're not following this 4-week recommendation or longer, they can experience some withdrawal. They have lower pain thresholds, which then we're using more pain medications, more opioids, which is what we want to do the opposite of. And we can see an increase in opioid use, especially in that first 72 hours. So this is really impactful. And if you're in the clinic, you can encourage your patients to utilize this before surgery. Okay, so then we talk about preoperative. So this is once they're in the hospital right before surgery. What things do we recommend? The American Society of Anesthesia recommends fasting from light meals at least 6 hours before surgery, from fried food or high-fat content at least 8 hours before surgery. And then they suggest that patients can have a modest intake of clear liquids for up to 2 hours before surgery. So this is very different. This is not the standard anesthesia, fast for 12 hours or 8 hours, and really does require, I was talking to Dr. Charleston, it does require buy-in from our anesthesiologist for sure, because this is a change in what was previously recommended. Do you see this, the fasting? Okay, so some are starting. Okay. Yeah. Okay. Awesome. Why do you think that this would be beneficial? Yep. What else? I ask a lot of questions, so I'm going to force you people to participate. Yes, it helps with glucose maintenance. That's perfect. One more thing, along with that, glucose. Yeah, exactly. So it does, it impacts their insulin resistance as well, which we know if we look at the outcomes of that, then their healing can be impacted. So yeah, very good. Another thing that the society recommends is, and ACOG recommends, is using a carbohydrate beverage prior to surgery. So they're doing that fasting for about 6 hours. We do the clear liquid fasting for 2, but then they give them preoperatively a carbohydrate beverage. And so then that does the exact same thing that we're talking about. It decreases that insulin resistance. It decreases their protein breakdown, enhances their return to bowel function, and then it decreases their length of stay, which I think is fascinating. There is no effect that they found in research on post-op complications, which is very encouraging as well. And then same with the fasting. For those that are still taking fluid intake and drinking that carbohydrate beverage, right before surgery, we have not found in research to have an increased risk of aspiration. So this is something I would anticipate that we would be changing in the future. Okay, so the other portions of the preoperative, the mechanical bowel prep, they are recommending that we avoid doing this, and for those same reasons. It causes the patient dehydration, it's discomfortable. We can have electrolyte disturbances, which then requires them to have more fluids after delivery, or after, I'm a postpartum nurse, so delivery is like natural. After surgery, and we'll talk a little bit more about the, the fluids and things like that afterwards. But so really that is the recommendation. And when they look at research, again, because I'm that research nerd, there are several randomized controlled trials, so those RCTs, that studied patients with minimally invasive gynecological surgeries, so those robotic surgeries and those ones that, the less invasive ones that Dr. Charleston mentioned. And it showed conclusively, all these studies that they looked at, that it is not associated with improved intraoperative visualization, ease of bowel handling, or procedure performance. So a lot of times I think I've heard, traditionally that you empty the bowels and we do that bowel prep so they can have the ease of seeing things and manipulating things and moving things. And when they looked at these studies, they found the opposite. So just interesting to kind of file away. And then 4 meta-analyses showed that it was not associated with a decrease in overall mortality, surgical site infection, leak rate, or reoperation. So lots of research to support that. And then if we look at preemptive analgesia, this is a big one, especially we're looking at decreasing our opioid rates and our consumption with our patients. And really with this, our goal is to optimize pain management with minimal opioid exposure. So we're trying to reduce that as much as we can. They use what we call a medication cocktail. And do you guys have, there's 3 components to that. Do you guys have any ideas of what we would give preoperatively for those 3 medications? Tylenol? Gabapentin, yep. And Motrin, actually, is what they recommend. But that would be another, ibuprofen. What did you say? Meloxicam? Okay. See, that's good to know. I like that. So they do meloxicam, Tylenol, and gabapentin. Okay. When we look at research as far as that medication cocktail as well, that pre-op gabapentin has lots of new evidence that's coming out. It's very interesting, and even looking at like a postpartum patient, there's some research done on those patients as well. But it is shown to reduce overall pain scores and opioid consumption, and then it has opioid-sparing effects. So we don't see the nausea after surgery that we would with those that have opioids. We have reduced incidence of constipation and different things like that. So if you guys want to Google, that is a really fun one to do. There's lots of different research that supports using that afterwards, which is interesting. Now it does, side note, it can't have the same addictive components that opioids do. So we still would want to use that with caution with patients, and it wouldn't be a long-term intervention, but short-term for that surgery, it really enhances their recovery. Okay, so then we look at intraoperatively. So obviously we want a minimally invasive surgery. That would be ideal. We want to use non-opioid analgesia during surgery as well. And then the 2 main components that are starred are the euvolemia and then that normothermia. So we're focusing, or the focus from the society, they really want to emphasize maintaining that fluid level that is as normal for the patient as possible. Yes, please. So it's like so it's having a good balance of your volume, fluid volume in your body. Just like with normothermia, we want a normal temperature. So it's just that normal fluid balance. Yeah, that's a great question. So if we look at the euvolemia, having that normal fluid amount, research shows that it decreases their post-op complications, it promotes earlier return of bowel function, and it decreases their hospital stay. And they recommend what we call a 3-pronged approach. So that's just using pre-operatively, intraoperatively, and post-op recommendations, and having the buy-in from all those 3 areas to promote that maintenance of fluid in our patients. And so what they recommend preoperatively is, again, the same thing I mentioned earlier, the clear fluids for up to 2 hours, a carbohydrate drink, and avoiding the mechanical bowel prep. Those are the ones that we would do pre-op. Intraoperatively, we know now from research that total loss of fluid during surgery is less than what they previously thought. And so the recommendation for anesthesia and those that are maintaining fluids in surgery is to only replace insensible losses. So they're not pumping these patients full with fluid. That's the recommendation, is to stop that, but just to give them what they need based on their fluid loss only. So that's kind of interesting as well. And then finally, post-op, we want a rapid transition to oral intake and get rid of the IV fluids as soon as possible. And I'll talk a little bit about what the post-op recommendation is. It'll be on the next slide. But basically, after delivery, the goal is that once they can consume 600 mLs of fluid orally, see, I say it every time. After surgery, it's like in my brain. After surgery, once they consume 600 mLs of fluid, then that IV is gone. We just lock it and leave it there, and they have no more IV fluid infusion. And even when we do that infusion, it's very small. It's just like 40 mLs is what they recommend an hour, so just very small amount. Let the patients drink on their own. We want them to increase their GI intake as soon as possible, and they have a better outcome. And then when we look at the normothermia, keeping that temperature normal, making sure that they're not cool in the OR and after when they come up from recovery, that decreases their coagulopathy, it decreases their risk of blood loss, it improves their wound healing and their immune activation. And these are just the basic things that you guys know. So making sure that room is warm, using a fluid warmer if you guys have one, if you're infusing IV fluids, and then those forced air infusion blankets. And if you're intraoperative nurse, if you're in the OR, please don't throw your air blankets, your forced air blankets away. Keep them and send them up when they come post-op, because sometimes we'll have those patients that cool on the way, and then we need to reutilize that again, because this normothermia, this concept, goes in surgery and that immediate post-op as well for it to be effective. So when we look at persistent hypothermia, what do you guys, if that patient's cold, what is their risk? Like, what would happen if they're cold? Physiologically, vasoconstriction, and then what does that do? Yes, and so then they have what because of decreased perfusion? There's no oxygen to the tissues. Yeah. Yep, exactly. Yep, so it's very important that we do this. And I found it fascinating. The Society says it in one of their articles. Even less than 1 degree Celsius can significantly increase their blood loss, which I think is fascinating. So obviously we want to reduce their blood loss after surgery, so keep your patients warm. And that's something that we don't really need an order for. You can do that on your own. Okay. So then when we look at post-op, I'm almost done talking. I'm sorry, I just ramble on. Here are the main things. So early line removal, which I mentioned a little bit earlier, and this doesn't just go with the IVs, but this is Foley's. These are our drains, different things like that. They recommend getting rid of them as soon as possible. The Foley's probably going to be your first one to go. And then we look at euvolemia, mobilization, diet advancement, and then again the analgesia components as well. As far as the euvolemia goes, I mentioned this earlier, they are recommending just a small infusion rate, that 40 mLs or less, and letting that patient really advance that fluid intake on their own. And we want it to be oral. That's the big emphasis with that. As far as mobilization goes, you guys know early and often, the standard recommendation through the society and through ACOG is 2 hours of ambulation the first day of recovery, and then at least 6 hours of activity each day afterwards. So that was kind of shocking to me. I feel like that was a lot. Please space it out. Don't tell them to walk 6 hours, but like a little bit at a time, and it really does that up. And I think if you give your patients a goal with that amount in mind, it really encourages them and reinforces, like, you need to move often. We can't sit for 4 to 6 hours. So. And then when we look at the early diet advancement, that decreases our length of stay. It decreases the risk of the post-op ileus. We want them to have a full regular diet within 24 hours would be ideal. And then some options that are just easy is the gum chewing and then the coffee consumption. Have you guys, I'm sure the gum intake or the gum chewing is more common. Anyone encouraging patients or utilizing that? Do you guys do gum chewing? You're pre-op. So you don't chew gum before. That's the opposite. There is some, I will tell you, there is some conflicting evidence as far as the benefits of the gum chewing. There are research studies that show that it decreased the risk of ileus and it improved motility. There's other more current studies that showed that obviously it improved motility, but it didn't decrease the risk of ileus, but no studies showed harm. So it certainly is not going to hurt anything to have them start chewing gum earlier. But what I found fascinating was that there was a recent study that found that post-op coffee consumption reduced an ileus rate in women that underwent gyn-onc surgery from 30% to 10%. So that was fascinating. And that was within the first couple hours once they were having that first fluid intake, to start with the coffee consumption after they had their water intake of 600 mLs. So file that one away. That was fun. And then when we look at the multimodal analgesia, same thing as what we mentioned before. 2 medications are more effective than 1. I can say I feel like we here at Women's, we do lots of Tylenol and Motrin, and alternating, every 8 hours for both, so they get something every 4 hours. A Motrin, 4 hours later, a Tylenol, 4 hours later, a Motrin, and really sticking with that. And that does definitely decrease their use of opioids and narcotics. Would you say the same, do you think, for your patients, Beth? Yeah. Oral is always preferred over IV. So again, we want to get rid of those lines and IV usage as early as possible. So encouraging your patients to drink that water and to take those oral medications is ideal. And then there is some research, like I had mentioned, on using that gabapentin after delivery. It can be more effective than the opioids, but we don't have a lot of research. I said it again. I'm so sorry. We don't have a lot of research on the long-term effects of using that. So now we have all this research on opioids and the addictive components and our patients that are abusing those, but there's not a lot of research on that gabapentin and what those long-term potential effects could be. So we know that they do have that addictive component, so we would want to be careful with the uses of those. But are there any things I didn't mention that you guys are utilizing, or what do you feel like works well as far as like the pre-op? Did I miss anything from the pre-op? No.
And most of our information comes from the recovery room nurses.
Yeah.
When we first started doing it, they could tell the patients that had pre-op stuff done.
Seriously.
Yes.
That's awesome. So what would you say was the difference? Like the main things that they would say?
They just think that they come out more comfortable.
Yeah.
They're not needing as much narcotics.
Yeah, so that pain is decreased would probably be the main one. Yeah. Any other? Yeah.
I've heard about this for a long, long time, but we haven't utilized it. And the reason that I work in pre-op and post-op here.
Okay. Yeah.
The reason I was told we don't utilize it is because of patient complaints that they think they can drink or stop drinking 2 hours before surgery. A lot of times they might just drink right up until, or they might not be empty at 6 hours. Was the reason I was told that we aren't using it.
Interesting. Okay. Interesting. I know that at Women's that they are working on enhanced recovery with C-sections. So that is probably the first I would say that we would see here. I guess I would argue that if they're going to abuse a 6-hour recommendation, they'll probably be likely to abuse an 8-hour recommendation. But and just really educating our patients. I think if we do a good job of teaching them the benefits, of sticking with that guideline, how it can improve their outcome, hopefully that would make a difference. But yeah, definitely. But really, speak to your providers. I would say advocate for your patients. Squeaky wheel gets the grease. So the more we can ask and say, hey, have you heard about enhanced recovery, or have you thought about trying a few of these things? I would venture to guess that they might be more receptive the more that they are asked to. That's great feedback.
Interestingly enough, I had a call case that was a C-section, and she was so seriously overloaded that she had balls in her basis, and I couldn't get her oxygen on.
Yeah. That's so scary.
I mean, she was seriously overloaded. I don't know how that happened because I wasn't there, but
it's harder too, I will say, with those, if it's an emergency C-section, most likely they've labored for hours beforehand. So then our fluid, that euvolemia, is totally different than that patient that walks into surgery, and they're stable and they've drank a couple hours before and different things like that, where if our patients are laboring, depending on what their blood pressure is looking like and different things like that, it is far more likely that they would have a fluid overload. Yeah, so we have to be careful with those too, and that's good feedback. It is interesting. Any other questions or feedback at all? Do you feel like, this is like the teacher in me, what are 2 things, from today, from what Dr. Charleston talked about or what Jen talked about, or from the enhanced recovery that you guys are going to take back with you that will either help your practice or enhance your practice, or we'll go around the room if people don't answer.
The terminology of it and the description of it when we have patients that come in for this.
Yes.
It's kind of important that we really understand what we're saying to them.
Yes, and like as a nurse that is not really med-surg, that's not my background, but floating to the GYN floor and taking care of those patients, getting report, I'd be like, I'm going to have to Google all the things that you're telling me that she had done because I have no idea what you're talking about. So it is very helpful, to have that visual. And I think I didn't, to even realize the difference of combining those different surgeries and where all those stitches might be and things that are pulled. And that definitely helps. So, yeah. What else, you guys?
just a review of the enhanced recovery is good.
Yeah.
Someday we might use it.
Yeah, hopefully sooner than later. Yeah. You can try the gum and the coffee. That doesn't require an order. Yep, good.
A lot of that medication preoperatively in the enhanced recovery is really driven by anesthesia.
Definitely.
Rather than the physician
Yep.
with following the same practices is very difficult.
Yes, absolutely. Yeah, I agree with you. And that's what I had mentioned at the beginning, just that multidisciplinary. It's hard when you have to have buy-in from so many different avenues. But hopefully, like this research that I showed you guys is from this year. So hopefully, that's something that as it's new and comes out and we start to utilize it more at Maine, hopefully that will come out to women's here too. And we'll see that, for all of our surgeries. So. Yes, yep, significantly. Yes. Yeah, I know, very cool.
GI doctors with all the bowel surgeries and everything, I mean, I've been in nursing for a long time, and when they do bowel surgeries, way back when, you kept the bowel quiet for at least a week. I mean, so
Yep.
how they feel about starting a regular diet within 24 hours to get that bowel.
So that I don't have the answer to, but I can research. The Enhanced Recovery Society has recommendations for all different types of surgeries. So what I presented today is just strictly gynecologic surgery. So yeah, but they do have recommendations for bowel surgeries and all different things as well. So you can go, if you just Google Enhanced Recovery Society, you can go on their website and they have them all available. So they would have specifics for like the bowel surgeries as well and what's different. Bowel preps might be different for those patients, obviously, than those that are having a gynecological surgery. So that's a good question. But yeah, and they have their very basic guidelines, step by step by step, just like this one is too. Easy to understand. So if you are motivated and you guys do want to come up with a committee or, start to get the ball rolling, you have those resources available. You can email me too. Yeah.
With the coffee, is that the caffeine that causes it, or is it just like would tea, for instance, do the same effect?
They, that's a good question. The studies that I read, it just looked at coffee versus they didn't look at soda, which would be dehydrating, so we wouldn't do that, and didn't look at tea, but that's a really good question. I will have to look. I don't have the answer to that, but I can research it and let you know. Anything else, you guys?
For a lot of the big bowel surgeries too, we also give medication that does encourage return of bowel function.
It's really expensive though, is why they want to do that.
It is, yeah.
We still get over there for the big bowel procedures where there's
Sure.
concern that it's not going to wake up.
Right. And then do they do like chewing of gum and anything that's non-medicinal? Okay.
But those are the ones that get the apple juice before they come
Okay.
in, And I think a lot of times it is, they don't, we get more and more where they've told them specifically how many hours ahead of their procedure that they can eat.
Yep.
But sometimes the surgeons don't like that because, they might want to move up surgery and then they
Yeah.
need too short an amount of time and
Yep.
they can't fiddle with the schedule.
Yes.
It's still and feel it.
Sure. Okay. Just to have that flexibility of being able to move ahead of time or whatever. Okay, that makes sense. So that's definitely a barrier to utilizing guidelines. Yeah, for sure.
That's more to visualize the ureters.
So the color of the urine is more for us to confirm patency of the ureters. We used to give methylene blue, indigo carmine, not methylene blue, indigo carmine, but there was a shortage of it. So then it was switched to pyridium orally. And so then we can see the orange urine come out of the ureters to confirm that they're patent. It probably has that a benefit of decreasing spasms, but that's not what we usually use it for. Mm-hmm. Yeah. It's for help with pain, yeah. Yeah, yeah.
So really it's important that they get that pretty early.
So that it's,
Starts working through their system.
yeah, and especially if it's a shorter case. The longer cases, then we do that at the very last thing usually to see, but yeah.
When we do it, are they taking it at home pre-op?
Nope, just your one dose is all it takes. Yep. I think an hour would be a good time. Yeah. Learn something new. Any other questions for me?
Do you guys have any questions on education and what to reinforce or teach before and after for Jen at all? Let me cover most things, but that was the main thing. Sorry, I'm not seeing the microphone.
Thanks. That with the education, again, just to reinforce, that's the one thing that if I were to emphasize is using the recommendations that Jen said and then reinforcing that, throughout. And a lot of the research encourages like us to tell patients, hey, when you come to the hospital, bring the paperwork and the handouts that your provider gave you preoperatively with you. So if you do have an opportunity to do those phone calls ahead of time, pre-surgery phone calls or different things like that, you can encourage your patients to bring those packets. So then you're going over the same information that your provider went over beforehand, looking at the same paperwork, reinforcing it again, and then they're taking it back with them and seeing that same information when they go for their post-op visit. So.
I was just wondering if our creams, I don't do the post-op or I don't work on the floors, but does our creams, the printed sheets follow what is taught preoperatively in the office?
The basic things, so with the creams, the basic things as far as the lifting guidelines, the no bath, nothing vaginally. Beth, you would probably be able to help me more. Those things are all standard for those pamphlets. But then there are some recommendations that are more provider specific that are not in creams. And so like Dr. Bracken has a paper that she hands that we give patients for avoiding trials, I think, that follows her guidelines, but they're different because they're provider specific. We are working on having more of a standard education that would be available in creams for these patients. That's just more of a Urogyne perspective, that broad perspective, versus a specific mid-urethral sling or a specific surgery. Because a lot of the recommendations are just standard across the board. There's very few differences really that would be specific. So that should hopefully be coming soon. But yeah, as far as those standard things, those basic things are in creams. And like when to call the doctor, fever, bleeding. Absolutely. Yes, absolutely. And a lot of the education that Jen uses and hands out, those are the handouts, right, Jen, that are on the table over here too. So if they do happen to bring them in with them, or you can pull them up online too, that OGS, the organization, is at the top of those. So you guys can also pull those up if patients have questions about their surgery, what type they had, need a reminder of what was done, or if you want a visual that's easy to understand, you can go online and find any of those. They're all available on there too, so then we can reinforce that as well. Anything as far as creams goes that's institution specific, they will not put on creams. So those are only like general guidelines. So these won't ever be on creams, in the Methodist system, but you guys can still pull them up online and show them to patients and utilize them too. So yeah, that's a good question. Anything else? Counting 5 seconds in my head. That's what they taught me in grad school. Okay. Okay. Well, thank you so much for coming. If you have questions that you want to ask, after, we will be available to chit chat if you want. And feel free, you can email me, Ashley Denker, Denker is my last name. So if you go home and you think of something that you're like, shoot, I wish I would have asked, I can send it to Jen and Dr. Charleston and or research it for you too. So, okay. Thanks, guys.